Right, good morning, everyone. My name is Darshan Mehta. I'm the Medical and Education Director for the Osher Center for Integrative Health here at Brigham and Women's Hospital and Harvard Medical School. And it's really my delight to invite you all to our November Grand Rounds. We have an exciting presentation ahead of us, so let me just share my slides. So today we're excited to have Dr. Rupal Patel, who will give a presentation tapping into the sound of health. And before I introduce her in just a moment, I just wanted to give a couple of quick pointers. For CME credit, for live participation at today's Grand Rounds, please email us at hmsoshercenter@bwh.harvard.edu, and please include your full name, your degree, and your institution. This is in a webinar style format. Please type your questions into the Q&A box. I will curate them, and then we will be able to ask them at the end of the presentation. As you know, this meeting is being recorded, and it will be available on our oshercenter.org website, as well as our Osher Center YouTube channel as well. Before we get started, just as a reminder, I'm attending. Are you? Join us to explore the science, practice, and community of Tai Chi and Qigong for whole person health. This is a really world-class state-of-the-art and science of Tai Chi and Qigong on April 30th and May 1st of 2026. It will be held at the Martin Conference Center here at Harvard Medical School. And it's a science of Tai Chi and Qigong as whole person health, deepening our physiological understanding of mind-body integration. And then just as a quick related, just so everyone is aware who's here at the beginning of the call, the Osher pilot research grants provide seed grants to support collaborative projects consistent with the domains of research and Osher's evolving 2021 26 strategic plan. So we have pilot grants available for 25 to 50,000 for 12 months. The letters of intent are due January 30th, 2026, and all members of the Harvard Medical School research community with a faculty appointment of instructor and above are invited to apply. And just as a preview, those of you, please just note on, we have our, on December 2nd, Tuesday, in person, as well as online Grand Rounds with Dr. Andrew Weil. Some of you may know it's going to be our Jack Hogan Integrative Medicine Endowed Annual Lecture, Integrative Medicine's Role in the Future of Healthcare, a reflection of my 50 years in the field. And if you're able to come in person, there's also a reception. So please, all this information is on the oshercenter.org website. And here's the QR code as well. Okay, so let me stop my share here. Okay, so really it's my joy and delight to introduce my colleague and friend, Dr. Rupal Patel. Dr. Patel is a professor at Northeastern University with joint appointments in the Department of Communication Sciences and Disorders at the Corey College of Computer Sciences and a core faculty member at the Institute for Experiential AI. She's been on Northeastern faculty since 2003 and directs the Voice of Women Vox Lab and the Applied Speech Technology Research and Innovation Center, where her teams investigate speech and voice as a dynamic, non-invasive biomarkers of neurological and physiological health. Dr. Patel is also an entrepreneur, having founded Vocal ID, a spin-out from a research that pioneered the creation of personalized synthetic voices for text-to-speech systems. She served as CEO until the company's acquisition by Veritone in 2022, where she became the Vice President of Voice AI and Accessibility, leading generative AI initiatives across media, talent acquisition, and regulated sectors. Returning to Northeastern full-time in 2024, her research leverages voice as a window into health, advancing the idea of the sound of health to transform how conditions are diagnosed, monitored, and treated. So we're really excited again to have Dr. Patel, and I will turn it over to her.
Thank you, Darshan, for that great introduction. It is really a pleasure to be here today, and I'm excited to talk about this work. So let me just get my slides showing, and then we can get underway. Okay, I hope you're seeing this. As Darshan mentioned, we're going to be talking about how we can tap into the sound of health. I just want to start with some disclosures. I'm a professor, as Darshan mentioned, and I have the Vox Lab, as well as Asterisk has been renamed the Center of Wealth, which is women's health. I'm also an unpaid advisor with fractional options and equity stake in Zana, which I'm going to be talking about today, as well Tatva Health and Hey Freya, all of which are doing some work in this voice space as well, using voice as a biomarker. Okay, so my objectives today in this seminar are to help explain why voice, what is so important about voice, what is how can it be used, how can it be integrated with different health protocols, and then I'm going to use some use cases in mental health, in neurology, cardiology, respiratory, sleep health, and endocrine health, just to kind of show how voice is being used as this new non-invasive biomarker. We will also touch at the end on limitations in data governance as well as ethics, because this does bring up a number of those issues as well. Okay, so first of all, listening is not new to medicine. Listening has been around for centuries, right? Doctors and medical professionals use listening as a key instrument. First, they would put their ear right on the patient and try to understand what was going on, especially in fields like cardiology, pulmonology, and vascular health, and so on. But in 1816, Laennec invented the stethoscope, and the stethoscope allowed us to have mediated auscultation, meaning that there was a tool in between the patient and the doctor. And this turned listening into an instrument, a clinical tool, where you could have more objective things that you would be measuring, and there would be repeatable measures and protocols that you could teach other diagnosticians as well. So I want to argue that we have a new tool, a microphone, and now that microphone sits in every one of our pockets, our phone. And this listening tool itself is highly powerful and can help us listen in a brand new way and at scale, not just for the patient that's right in front of us, but also for patients that may be remote or not directly in front of us for that time. So I want to argue that listening is a new art in this age of AI and in sort of new digital signal processing capabilities. So we'll start with the vignette. This vignette is of a young man named James. He's 68 years old. He's living with stable heart failure. So James woke up today feeling a little off. His daughter reported that his scale on his weight, his weight on his scale was unchanged. His BP was unchanged. His pulse was fine. She got really scared because Dad said, I'm feeling a little off today. So she came over and checked all these things. Everything was fine. But he decided he was too tired, so he skipped his pulmonary rehab this week. But then 3 days later, he ends up in urgent care with shortness of breath. What could voice have caught? And this is really the question that we have is, well, what voice would have caught is that we would have been able to, if he'd gone into that rehab session, or if we had trained the daughter to actually listen to some of the signs, the subtle signs that he is going into decompensation. We would have caught the shortness of breath. We would have caught the shorter phrases, more pauses in between sentences, a slight subtle change of his pitch range. He couldn't really maybe monitor or change his pitch to high pitches as well as low pitches. And so it's starting to sound more flat. These would be early vocal signs that he was starting to go into decompensation. Things like weight, BP, pulse, they might look normal for a while, but they don't actually decompensate until much later. So voice is this early sign that could have been detected within 20 to 30 seconds of that initial, just with a 20 to 30 second sample. All right. So here's what I'm just trying to have it's hard for me to see my entire screen here. So here, what we have is a number of tasks that we use in order to understand what may be going on with different subsystems in the body. So the tasks include things like a sustained vowel, something that we call diadodokinesis, which is saying pa 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 as fast as you can for 5 seconds, ta 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 as fast as you can, and ka 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 ka. These are all different consonant vowel combinations that are occurring at different places of articulation in the mouth. Pa 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 at the lips, ta 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 at the alveolar ridge, just right behind your upper teeth, and ka 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 toward the back of the tongue. Counting, and then we also combine them together as pataka, looking at the coordination. So diadodokinesis can be done really quickly. We can also ask someone to count from 1 to 20, and then read a small passage as well as some expository speech, such as like, how do you make a peanut butter and jelly sandwich or something of that sort. These are the kinds of questions we may ask or the kinds of tasks we may do, usually taking less than around 2 minutes to complete. And what we're looking for is the ability then to see if we can tap into the various different subsystems of speech production. So respiration, phonation, at what's happening at the vocal folds, articulation, what's happening in the vocal tract, the lips, all the way from the glottis, all the way to the lips, and then prosody, which is this melody of speech, which is actually a coordinative system where you're coordinating respiration, phonation, and articulation together. So here, what you're looking at is a sustained vowel. This is a spectrogram and an acoustic wave. So the top part of it shows you an acoustic wave. This is an individual saying, and holding it for as long as they can. So what we can see here is that the acoustic wave is on the bottom, the spectrogram is on the bottom. The acoustic wave shows you, is on the top, sorry. It is showing you change of intensity over time. The spectrogram on the bottom is showing you frequency on this axis and time on the bottom axis, and loudness or intensity is shown as the darkness. Because they're sustaining the vowel ah, you see these dark horizontal bands, those are called formants. The formants are relatively constant. If we are moving our articulators in the mouth, those formants would change over time. So when we're speaking, we're basically changing the articulatory positions in the mouth, and those will correspond to these formants, which are the resonance of the vocal tract. What I've highlighted here is a few things in this sustained ah production. There's a gentle blue line here, which is tracking the pitch of someone's voice, of this individual's voice. And what we see is the average pitch is 233 hertz here for this person. So it's likely a female. Average male pitches are around 100 to 110 hertz. And then we also see measures such as jitter and shimmer. Jitter is the cycle-to-cycle variation in the pitch, and shimmer is cycle-to-cycle variation in the intensity. These are precision measures. So if jitter is high or shimmer is high, it means that the vocal fold precision is low. And then down here, I've circled that the duration of the sustained vowel is about 5 seconds long, where it's probably not, we probably didn't ask this individual to hold it for as long as they can. And so we don't have a very long sample. Generally, we ask someone to take a deep breath and then sustain the ah. That gives us an idea of the respiratory volume. So from just a sustained ah, we can get what is happening at the laryngeal level and what is happening at the respiratory level. This next task I'm showing you is essentially counting to 20. And this individual is now counted to 20. You can see from the acoustic wave on the top and from the spectrogram on the bottom again. They have to take a breath between 17 and 18, which is shown as sort of silence on the acoustic wave and just noise or not actual speech on the bottom here. And because this individual is producing not just a sustained vowel now and saying 1, 2, 3, 4, 5, and so on, you're seeing that the darker bands, if I had zoomed in more, you would see that the darker bands are moving. The bands, the formants are basically just a representation of how the articulators are moving in the mouth. And also we can detect sort of how long it took the individual to say this, to count to 20. That tells us about the rate of speech. That also tells us a little bit about the respiratory volume. So again, counting gives us an idea about respiration, phonation, but now we can look at the precision of how they count all these different numbers and whether or not there's precision in their articulation as well. So lots sort of just from these very, very short tasks. So just to fill out that chart that I was talking about earlier, all of these tasks tap into different kinds of cues that we are measuring. So with just this small battery of 2 minutes, we can test all of these subsystems, and they are important for numerous different kinds of health conditions. So how do we do all this? I mean, before we got on the call, Peter was asking, is it okay to just use a Zoom call? Is it okay to just use a phone? Actually, this technology has evolved considerably. Your phone and the microphone on the cell phone is incredibly good at collecting voice. And now also with things like Zoom, as you probably noticed, the noise collection on Zoom, or the noise detection on Zoom, is really quite good. And so you can filter out the noise from the speaker who is talking. Sometimes that does impact the voice that you also want to record. And so most times we record in a non-noise canceling situation. But there are also external things that you can do after their voice recording has been collected to make sure that you are only collecting the audio that you want to collect, and to filter out the noise aspects, such as electrical noise in the background, ambient noise that we don't want to be listening to, and so on and so forth. So has been a considerable amount of technological leap so that we can move from the lab to the home. In fact, COVID has this acceleration for us in terms of what we're capable of doing. But even before COVID, there were more and more microphone arrays inside this phone that would cancel out where the directionality of the microphone as well, in terms of who's speaking and who's listening. When we pair voice capture with other physiological sensors and patient-reported norms, we start to get a much more comprehensive picture of what is happening with the patient. So when we have physiological sensors, such as from the Garmin device, or Whoop, or Aura, these are all trying to tap into other signals. Voice is just another time-varying signal that we can use. And then when we have patient-reported outcome measures, we are now seeing what the lived experience is when people are experiencing these various different, as we collect the voice as well. So what we're looking at when we capture voice is we're looking for within-person differences and detecting with sensitivity and specificity what is happening in terms of their condition at that point in time, but we can also look at deterioration and recovery over time. We can also look at things like what is the response to medication, response to treatment, and so on. In addition to just within individual differences, we can also look at between individual differences as a way to triage, as a way to screen for conditions, and as a way to calibrate for clinical settings as well. So let's go into sort of so this video here is actually showing an individual using the Xana app. This app, this company is out of Germany and also has a US presence as well. And what you're seeing here is what the protocol looks like as they collect audio. So that's the sustained and it's going to process it. And it was initially asking for mic calibration, and then was asking for the sustained and now it's going to ask for more phrases. So the individual is going to record a phrase, and then we're going to listen back to it.
My mind and body are in perfect harmony.
Clearly, she's trying to be quiet.
The day was quite productive. I had a great start of the day.
And that was an example of or just saying something extemporaneously. So basically, the Xana app is used for collecting the audio sample and then doing the analysis. And as I'm going on in the talk, I'll actually show some of the visualizations and some of the biofeedback that's also possible with apps like this. Okay, so what is the evidence across the different subsystems, or across various different disease populations or conditions? Well, first, in mental health, voice has been used quite a bit for management and screening of depression, anxiety, as well as stress, depression being the most furthest along, which I'm going to give you an example of. And then in progressive neurological diseases, there's been a lot of work in Parkinson's disease to show how voice is used to detect Parkinson's years before sometimes even the gross motor signs come up. So we can see slight progression of the disease even earlier. In cardiology, there's risk prevention and prediction with heart failure. In endocrine diseases, we can look at hormonal changes and how those hormonal changes may actually confound what we measure for these other conditions. And then in sleep and respiration, there's been work not on the patient's speech, but actually on the snoring to detect and screen for just regular snoring versus obstructive sleep apnea. So let's take each of those in turn. So in mental health and depression, undiagnosed depression directly impacts treatment, right? The cost for treatment for undiagnosed depression can rise, increase costs by 2 to 8 times. So payers and systems, all of us end up paying for that if the disease is not, or if the condition is not caught earlier. And there was a study by a group that is creating this app called Kintsugi Voice. And Kintsugi Voice essentially looks at ways in which primary care physicians can detect depression just from a simple screening. This is a screener. It is not meant to be the diagnostic tool, but it's meant to be able to get at patients who don't come in, who may be in remote areas, and who we could detect early. They're working with employers as an employee educational tool to help people screen so that they know when to go get further evaluation. And there was a study that was just published now in the Annals of Family Medicine in 2025 by Mazur et al. That showed this Kintsugi voice version 1 for 14,900 patients, just by asking, how was your day? The model that they had developed was able to identify moderate to severe depression and have that as the reference was the PHQ-9. They were able to detect with the sensitivity of about 71.3% and specificity of about 73%. And also then refer about 20% of the cases to say we needed further evaluation. So it wasn't trying to detect 100% of the cases. It was basically saying, what can we do? Can we find that is enough of a correlation between the PHQ-9 and this voice measure itself? And there's been other systematic reviews showing that depression changes the voice characteristics in terms of the prosody. So pitch range becomes much narrower. There is usually a slower rate of speech. There is sometimes more pausing in between phrases, more intentionality, voice quality changes as well, changes in shimmer and jitter, as I told you about the constraints at the vocal fold level. So a lot of cues, a lot of work has gone into detecting and screening for depression. There's been some work on looking at acute stress, mostly in conditions like, if you're at high G-force and things of that sort, not necessarily practical kinds of things that we might say in everyday life. But here, there are also other biomarkers for voice in conditions like that. For example, high FO, so higher pitch, as well as just being able to increase their intensity goes up. Anxiety is another condition where we've looked at changes in voice, but that needs much more external validation. So this is some work that is going on for apps such as, or for platforms such as Hey Freya, where they're looking at how is voice correlated to stress and how is it correlated to anxiety and other conditions sort of in daily life. So moving on to neurology. Parkinson's disease of the progressive neurological conditions is one that has been studied a lot in voice. Max Little and his colleagues did a large study several years ago looking to see if they could tap into the telephone. This was before the cell phones. Cell phone usage was as penetrated as it is now. And they just used regular telephones, which are complicated in the sense that they kind of cut off the bandwidth of the acoustic signal from 50 hertz to 5,000 hertz. So it sort of limits what we can capture, whereas your cell phone is capturing voice at all the way up to 40,000 hertz, which gives us far more than what we do in speech, what humans are producing in speech anyway. But these studies kind of showed us that there are cues in voice that are detectable, and they show up much earlier than gross motor signs do, because voice is this fine motor skill. And because of that, we see subtle signs of changes in control, in motor control way ahead. And so if you can detect these voice changes ahead of time before the gross motor symptoms. We know that Parkinson's disease, where by the time the gross motor symptoms show up, there's about 80% of cell death in the substantia nigra. So if we can catch it earlier, it means we can also start intervention earlier and start drug therapy earlier. So this is a really important finding, and there's been a lot of work by Ramig and colleagues to show how accurate these voice measures, in fact, can be. It's also very low burden. And for that reason, it's also being used to track how medication can be delivered and how much of the medication dosage is necessary. So this study that I'm showing here was by Sousa et al. That was in Nature in 2025. And these graphs are showing, these radial graphs are showing, they're a little bit fuzzy on my screen actually, but they're showing what kinds of acoustic features differ for patients. Patients are in purple with medication off, and then patients with medication on are in blue. So we can see how the medication is impacting the patients. And then in the second graph on the side here is with patients, comparing patients and healthy controls, and we can see the features that vary for the patients versus for the healthy controls. This study was used to basically alter the medication dosage for the Parkinson's patients that were living remotely in between their visits to the clinic. So in between visits, sometimes it's not possible for patients to come in from rural areas. We see this also in many developing countries, but also here in the US. There's not a lot of coverage in states like Maine for patients to come in to see a neurologist, as often that they need to for the medication change. And so we see that there could be a very useful tool to use voice as this intermediary to fill in when they can't be seen in the clinic themselves. Moving on to pulmonary disease. So in pulmonary disease, this study is by Tuna et al. It was published in 2024. Here, this is in collaboration with Zana and Maastricht University. They enrolled 37 patients. What you're seeing on in this slide is a number of different pictures here. So the first is sort of what the enrollment timeline was. So they had enrolled 37 people. They prospectively enrolled these individuals who had COPD, and they wanted to see over a period of 12 weeks what happens in terms of can they detect using voice some of these exacerbation kinds of conditions, and can they detect it with voice? And also they asked the patients to report using a patient-reported scale called EXACT. And so you're seeing the exact score. So when the patient thinks something's going on, and then this is the days on the bottom. So the red dot is when they have an event, and that event is sort of time zero essentially in some ways. And then if you go back 7 days, that's the prodromal phase. That means 7 days past is the time period at which potentially you can detect a condition in voice before it's even necessarily seen as a condition or an event that someone needs to be hospitalized for. And then after that, they're hospitalized in the pink session, and then when they're better, they're now in the green. So from this graph here on the side, you can see that if the day zero is when you can obviously detect something's going on in voice by 85%, by day 3, you actually starting 3 days before that onset, you are able to detect the condition in voice by about 79% classification accuracy and 85% for the day of. So that's actually showing you that even before this individual knows that they're decompensating or going into this condition, they can in fact, voice can be used as a measure as an early warning sign. And then this is sort of similar to James, the case that we showed at the beginning. This is for cardiac disease or heart failure. When you have heart failure, this is a study by Barr and colleagues that was published in 2024. When you have heart failure, the top chart here is showing that not only the fluid retention in the heart then also affects other tissues, and because the larynx is a tissue that has a lot of epithelial tissue, or a structure that has a lot of epithelial tissue, that epithelial tissue will also have edema, and that edema will show up in the vocal folds, and that edema then will show up in the acoustic signal as a decrease in pitch, as a inability to kind of modulate the pitch as well as the intensity, and you can collect that in voice. So again, voice is showing up as this prognostic indicator for rehospitalization. So this study was with 131 patients, 91 males and 40 females. And here what they were looking as, again, it was a prospective study. They enrolled individuals when they were in this decompensated state and then watched to see with daily measures of voice what happened in the period while they were hospitalized and treated, to see how that voice signal changed over time until they were discharged. So it was just a binary classification. Can we detect that this voice sample is from an individual who is in a decompensated state versus a compensated state? And the sensitivity of that measurement was 81.7%, specificity of 79%, and accuracy of 80%. So again, really great sensitivities showing in terms of what the voice detection models are showing in terms of what is going on prior to detecting, even before their discharge, that we're seeing that you can see what the risk might be of them being hospitalized again. So in this graph here, basically, this is a spectrogram, again, showing the acoustic wave on top and spectrogram on the bottom. And I just wanted to show this as a way to show the difference between healthy speakers and a speaker who might be in heart failure. Heart failure might be someone like James, where you see these horizontal lines, these yellow horizontal lines that you see in the healthy speaker that are nice and crisp, are more blurred. These are called harmonics, and more blurred in the heart failure patient because they don't have steady control of their vocal folds. There's a lot more noise in the signal, and you can also tell that there's more vocal effort from how loud the signal is in the acoustic wave. This study was published, this is an image from a study published by Reddy et al. In 2021, where they also built an algorithm to differentiate between healthy speakers and those in acute heart failure. So lots being done in this space as well. So now I want to move on to sleep acoustics. In sleep acoustics, there's, as more and more devices are being put in patient rooms, as well as now we have ambient devices that are in our bedrooms, and then of course listening devices such as our phone that are in all of the spaces that we live in. We can detect not only voice, but also ambient sounds that we produce, right? Or other sounds that we produce, including snoring. It's not the tools that have been developed so far, or the models that have been developed so far, aren't useful for diagnostics of obstructive sleep apnea, but they certainly are useful for screening whether this individual might be snoring more often. So it's very good at detecting the snore episodes themselves, so the number or percentage of snoring, whether or not how long the snoring is happening for. And so the detection of, for screening whether or not this person needs to go into polysomnography testing in the lab can also be done by these ambient measurements at the home. And the accuracy of them is similar to the ambient devices that we're sending home for at-home sleep devices. So I think this is, again, an area where further research can be done, but we've seen a lot of really, really good research come out of here with correlations of all the way up to 0.93 with polysomnography. So polysomnography is the gold standard, costs a lot for individuals to go into the hospital to have this testing done. If we can do something like this and screen people in their own homes, we might actually be capturing more natural speech, because the day that you go into the hospital, you might not have the snoring episodes in the same way as you might have at home. And so it's super important that we rely on these tools in addition to the tools that we have as the gold standards that are in the hospitals as well. Last, I want to touch on confounding impacts. So the confounding impacts of hormones. This is a lot of where my lab is focusing, the Vox lab. We're really focusing on what happens in midlife. Midlife is a time where women particularly have much more of a change in their voice. Men's voice changes really happen during puberty, whereas women's voice changes happen primarily during menopause. That is because of the decrease in estrogen. Also, there's this change in progesterone and other androgens as well. This affects the laryngeal tissue. And there's shifts in pitch, there's shifts in the roughness of the voice and voice quality, and also vocal fatigue. Many women say that they can't project their voice in the same way during menopause or in the perimenopausal phase as the tissue becomes less pliant. What happens is we start breathing from our clavicles rather than breathing from the belly, which actually causes a lot of neck tension and headaches. In fact, most women who don't use their voice a lot will complain that that's what they feel is headaches and neck tension. Those who use their voice a lot, what we call voice super users, complain of this pain as well as the vocal issues as well. So tapping into the voice, I think, is one of the conditions where we haven't really looked at voice as one of the top signals of menopausal change, right? And now, as we are able to detect voice as this biomarker, we're looking more at these changes, especially in women who use their voice a lot for profession. In fact, most women who are teachers, most teachers are women. 75% of teachers are women. Many individuals who use their voice for the radio and for TV and for other kinds of professions where they're speaking a lot happen to be women as well. And so understanding the changes that are happening during menopause in terms of voice changes is really important. The other thing is these menopausal changes in voice, they also overlap a lot with the same kind of signals that we may see for progressive neurological diseases. And it's kind of interesting to me that progressive neurological diseases in men are detected, in their 60s and early, in like late 50s, early 60s, where we can do something about them. Whereas for women, for Parkinson's disease, for example, we're not detecting those changes until much later, meaning that we really can't do as much with them. So the prognostic indicators are much poorer for women. And a lot of this, I think, can be teased apart between whether or not these voice changes were subtle or whether they were taken for something like menopause for women and not for men. So I think it's really important to think about how these markers for our hormones or changes in hormonal status in men and women are going to impact the other conditions that we also want to tap into. So coming toward the end of my presentation, I want to consider some of the caveats. So some of the big caveats are the microphone that's being used, of course, the room acoustics. But as I said, the microphone issue is really one that is quite moot now. Depending on how you want to use the acoustics, there are different kinds of pre-filtering as well as post-data filtering that can be done. We did a lot of this work in my lab and as well as in the startup that I had, where we collected voice samples in the wild for about 100,000 people. And then we looked to see, well, how did those voice samples, what do we need to do to clean up those voice samples to actually use them? In fact, we were using them for a task such as creating synthetic voices, which was the highest kind of quality voices that we needed. And even then, we were able to build tools that were able to disambiguate the noise and keep only the speaker characteristics that we wanted. Of course, we talked a little bit about already the medication cycle. So if you record someone while they're on medication, that's going to have a difference than off medication. So voice is a very sensitive tool. And we need to be aware of how it varies with things like medication cycle, as well as time of day and diurnal cycles. So circadian rhythms change not only sleep, but they also change our voice. Voice for people who are using the voice throughout the day will sound very different at the beginning of the day toward the end, as well as toward the end of the day. Mood and other aspects of affect also change the voice. So voice carries with it not just acoustic information, but also linguistic information and prosodic information. So the tasks have to be designed in such a way that we're not confounding affect in what we're asking them to say with what we are measuring. So if you're asking them to say something that is very emotionally laden, the voice is going to be different and the cues are going to be different. And so we have to measure those and hold those controlled as well. The amount of sleep one has had can also affect voice quite a bit, and fatigue can as well. So these are all the confounds we need to be aware of. And then we have to design tasks that will control for them. One of the really cool things, though, about voice is that it's quite robust to language and it's robust to accent. So the work that we're doing with Xana in Germany and here in the US, as well as the UK in English, there's a lot of work that's been done on voice biomarkers across languages, across cultures, in order to show that it's quite a robust tool. In fact, sustaining a vowel can be done in any language, right? And we can look to see whether we can create these norms. So this work, there's some collaborative work that's happening from the Voice Institute in Luxembourg, and those of us here in Boston, and my colleagues at University of Southern Florida as well, where we're doing a lot of work to sort of create these norms. But we really need to know that voice is a very sensitive tool. It's this fine motor instrument, but it's not necessarily specific to disease. And so we have to do additional kinds of, collect additional kinds of information, such as physiological information, patient-reported information as well. So it becomes a really good tool for screening and monitoring, but not necessarily a gold standard for diagnostics itself. When we collect voice, we need to be very careful about how we store the data. The data needs to be stored in an anonymized fashion. Voice is personally identifiable information. And because of the high risk of fraud of voice information, using it for, for voice impersonation and so on, it's really important that the data itself is stored separately from the demographic data of the individual, so stored on different databases, in different storage areas, and so on and so forth. And also that the voice signals themselves, the raw audio, is protected from misuse as well. We can take and derive the signals from voice. Sometimes we're only interested in the prosodic signals. You don't have to store all of the raw audio. And so it's important to think about what needs to be stored and what can be removed immediately. So I want to just end by saying that I think that voice is this new vital signal. It's this fine motor instrument that can be influenced by a lot of different aspects of our body, by neurology, by anatomy, by physiology, and it can precede many of the symptoms and thus can serve as a very important screening biomarker. It's low friction, it's low cost, which means that we can use it in large populations. And so it fits into very well in integrative medicine and remote healthcare models. So I urge us all to start listening again with our microphones, with our spectra, and also, of course, with safeguards to enhance how we can do integrative care across the lifespan. And I invite all of us to collaborate, those of us that are on this call, to collaborate on projects where we can leverage voice as this low-cost, accessible, and inclusive tool. Thank you.
Wow, that was truly, truly amazing. I'm going to just share. Okay, yeah, perfect. Thank you, Rupal. There's like so many questions that are being generated here, but let me start with there's a phenomenal presentation. It just makes us think about what the future holds, and it also reminded me why we're excited to have you here. One question, there's a question in the Q&A, and I was actually thinking this very similar thing. So I'm gonna, it's a personal example. Both my mom and my masi, my mom's elder sister, as they went through menopause, they were singers prior to, and then they then had this embarrassment of singing, and is curious as to the has anyone studied one? So there's on the treatment side HRT, and how does that change voice? And the question asks, thinking about flexibility, and then what is it about certain singers when you think about somebody like, at least in the Indian diaspora, you have somebody like Lata Mangeshkar who sang all the way till like 90. What was it about that? Was that an indicator of health in some ways, or how do you see that?
Yeah, so I'll take the first question, the last question first, which is when you have people who are these prolific singers and continue to sing until late life, I mean, part of it is how they use their vocal instrument, how they adapt the vocal instrument as well, right? And so part of it is health, because of course you have to have good respiratory volume, you have to have good phonatory control to have, to be able to sing at that way for that long, and for also, and the posture. All of these things are really important to get the right respiratory volume and not overtax at the phonatory level, right? So when when women who have more trouble during menopause, and actually any singer, that, people who have vocal fold nodules, for example, it's because they're pressing too much from the larynx level, from the respiratory level, and pushing the folds together so much that wherever the folds are coming together, they're in fact causing these little calluses. Those are the nodules, right? And so there's this lack of or inability to control getting the volume loud enough and being able to control the pitch well enough, right? And so it's a learned skill. And for some people where it becomes part of their voice, like for Rod Stewart, it became part of his voice, this raspy kind of breathy voice, because he had so much difficulty with sort of that control. I think that the idea of looking at whether hormone replacement therapy can help singers in menopause, especially women, like women singers, is something that hasn't really been done. In fact, this is work that my lab and work that we're starting to do with the University of South Florida, where we want to look to see. We've got a couple of proposals in play right now, hoping that this comes through, because this is work where in the last 20 years or so, HRT has kind of gotten this bad rap where, we've been told we shouldn't be on our HRT, but then we know that it's osteoprotective, that it's also neuroprotective. And so women are going on HRT. And so can we now look to see, for women who are complaining of voice complaints, can we see a change in their voice, especially women who use their voice professionally, singers, voice actors. Many voice actors that I worked with often complain that they couldn't have jobs, in the same professions, like in the same areas anymore, and they had to use sort of different aspects of voice talent, where they do medical narration now instead of things like movies and so on.
Right. So one of the things you kind of alluded to, like there's the interdependence of sort of your posture, body shape, breath, your affect. One question is, what role do mind-body practices have in addressing voice signals, and can it serve as in addition to serving as a biomarker, can it inform mechanisms of the practice itself?
Yeah, I mean, this is the work that I'm doing with Tattva Health, right, where we are starting to do some of these ancient practices of breath work and sound work and Tai Chi, as Peter does. We'd love to explore this further. It's like, how does that change then the ability to control voice when your body is in a relaxed state of form, right? Like, and how can you reduce stress in your body? How will that then relate to the voice changes as well? I mean, it's not just for detecting health conditions, but I think the real opportunity here is, how do we then use interventions that will then, show up in voice as well? And how can we monitor the dosage of those interventions? How do we think about how long they need to be done for? All of these are really important questions that we need to answer. And I think we're just scratching the surface right now.
Have there been, I know you certainly showed some of the research applications, but have clinicians started to do you have examples of places where clinicians started to use this sort of voice, both from this is a screening tool, like it's happening, like clinical practice out there that have started using this as a screening tool? And are there examples that you're aware of in primary care or in specialty care as well?
Yeah, so in primary care, they are using the depression monitor with Kintsugi. So I think that they are doing that as a screening, right? And also the Mayo Clinic during COVID had done a lot of work on cough detection and signaling different kinds of cough. And so there was some work there. I don't know how much it actually made it into the clinic, but a lot of, actually in places like India, they were using the cough detection as a way to kind of then screen people who had to go into the hospital. So you could use the voice detection algorithm the cough detection algorithm to say, when should you go into the hospital, right? When should you get care? Just like we were using the tests here. And I think the one thing about voice that's really interesting is it's very cheap to do. So it can have a high false positive, but okay, so then you're going to go in and you're going to get it checked, right? So I don't know if there's that much negativity around that, especially for things where you can then finally get a better risk, better diagnostics when you get seen versus not being seen at all. I think that's the difference.
Okay. I think so. One thing, just think from a systems perspective. certainly in both in traditional Chinese medicine, and certainly in Ayurvedic practices, they've used voice characteristics or voice approaches like humming and humming techniques and has there been any sort of are you aware of any sort of examinations looking at in other sort of systems of medicine as well, in terms of how voice has been used or studied, both from the practitioner perspective, but obviously maybe even in a more technological, sort of sophisticated way as well?
Yeah, I mean, I think in neuroscience or in neurology, I think the idea of like voice control is, is obviously being used. But I think I mean, there is some question in the UPDRS around voice, but it's sort of like very general. It's not necessarily the precise kind of like what features are changing, and how are they changing? Can we detect them early? And I think the thing about voice is, if you're trained to listening to it, for example, I have a good friend of mine who now has been diagnosed with Parkinson's disease. About 10 years ago, when I first heard him, I said to my husband, something's wrong with his voice, right? There's, and I think that it's this, I had suspected it was Parkinson's, but partly because I have that in my family. I've heard people with that voice. So I think partly it's like, how subtle can the sign be and who is detecting it, right? And so I think the trained ear can pick it up. But now, our devices are our trained ears, right? And I think that now the accessibility of this, I could say even before 10 years, my lab was mostly people come into the lab. People come into the lab to do, these kinds of studies. We thought we had to be in an acoustic booth to do the recordings. And I think, we've sort of broken that system or thought about that differently now with COVID and also with the advancement on all the technology.
So I guess then the question becomes, as a follow-up, in medical education, there's sort of with the AI tools and such, there's a cognitive unlearning that happens because you're just so used to the tool that you forget if you didn't have the tool what it would sound like. And I'm curious, how as you're thinking about it, like we have technology, but if the tool was whatever, like we had the Amazon web crash happen, and then all of a sudden you got to now figure this out on your own. How much training is required so that the ear still has that memory as much as like how I don't know if there's any idea of like how we lose that.
That's a really interesting question. So like would clinicians say, well, I want to improve my ear versus just this crutch of this tool? And I think that's fascinating, but I feel like for many medical practitioners outside of probably speech and hearing sciences, probably that tool is not very well developed. And so potentially it could be used as a tool to train the ear. And then maybe you still use your ear, but you don't have your ear with you when the patient is at home. You don't have your ear with you when the patient is living remotely in some area that you can't access. And so it's a good tool to have in between. And also for patients who, are not going to be able to get the care that we can deliver for them in these highly trained places as well.
Great. I know you alluded to it, but there's questions and they're like, if people want to engage in research, which applications or how do they, and I know you mentioned it in your presentation, but if they want to, are there apps available or what for research that are publicly available, or is it all through sort of private industry and startups?
No, there's quite a bit of work. There's this Bridge to AI Voice project that was funded by the NIH. Yael Ben-Susan is the PI at the University of South Florida. She and I are colleagues and have been collaborating on quite a bit of work. It's a big consortium of lots of different universities and settings. In the US. Now there's this new one in Luxembourg and the EU that we're also going to be working together on. So there's data sets that are being created for different conditions, and those data sets are being used by machine learning specialists and so on to differentiate between these diseases. We're also collecting more data. What hasn't been happening so far as much, and I think this is where integrative medicine can be really helpful, is collecting voice data along with some of these other physiological instrumentation data, heart rate variability, all of this. I think it's really important for us to collect that data simultaneously with the voice data and synchronized. Much of the voice data that's been collected so far is like complete the voice biomarker, protocol, and maybe they do some proms along with it. But I think the comprehensive look is when you can do all of those together. So I think it's really important for that. So, reach out to us, reach out, and then I can put you in touch with other people that are doing similar kinds of work. Or if you want to add that voice instrumentation, we can certainly, and there's lots and lots of companies out there and ways to collect the data. Hopefully, we can also work with other organizations that can put voice into their protocols as well. In the clinic too.
Wonderful. I think I guess I think you sort of alluded to one of the questions that had was like, how does this work actually help influence therapists or clinicians actually enhance their work? So if you have a music therapy approach and with a patient, can you actually use this type of tool or to actually guide the therapist in how their work is actually influencing the prognosis or the clinical sort of presentation of the patient?
Yeah, just like I was showing in that example of medication, like the dosage and so on. Similarly, you can use the voice signals at the beginning of intervention as well as throughout intervention to detect how is it improving, right? How's the patient's voice improving? Is the therapy working? What features do we still need to work on, or what aspects of the voice do you still need to work on that's not, that's still aberrant from that's not working with therapy and so on. So yeah, I think there's many ways to use it as a continuous monitoring tool as well.
A sign of an amazing presentation is that we have lots of questions left to answer, but I would encourage our audience to reach out to Dr. Patel for research specific questions, and then other as she mentioned, there are ways of figuring out the right partners and such. So I just, on behalf of our entire team, thank you for an amazing. We look to have you back. I can imagine even a future presentation with a patient and how one of these tools was used to actually guide in a patient care situation. It would be amazing to just see the actual, like in real time application of how this in indirect patient care, how this might work too. So
I think, yes, actually, just to mention on that, I think there's people that are working on trying to get that approval of like what features can we use in the clinical setting, and I think that's going to be something that we're working on. So this field is early.
Yeah, wonderful. We're lucky to be at the cutting edge with you, and at least to showcase it. So thank you again. Spectacular presentation. So with that, I just want to just quickly remind everyone of just the remain. One second, let me just share my screen real quick. And oops, sorry. Okay. Okay, so I think it's not shared yet. Sorry. Okay, here we go. So again, just to we have our conference on April 30th and May 1st of 2026, The Science of Tai Chi and Qigong as Whole Person Health, Deepening Our Physiological Understanding of Mind-Body Integration. Again, please mark in your calendars, please plan to attend. It's going to be an amazing event. Just as a reminder, Osher Pilot Grants, maybe this presentation stimulated an idea for some of you. And we love, again, the grants are awarded annually, $25,000 to $50,000 for 12 months. Letter of intent is due on January 30th, 2026. And again, would invite you to apply. And then really excited to, we're going to have Dr. Andrew Weil, one of the sort of trailblazers and luminaries in the field of integrative health and medicine. And he will be here in person on Tuesday, December 2nd. If you're able to come in person, please do. There's the QR code, and if you're, obviously we'd love to have you virtually. This is entitled Integrative Medicine's Role in the Future of Healthcare, a reflection of my 50 years in the field. And this will be at the Brigham and Women's Hospital, 45 Francie in the Bornstein Amphitheater, and the reception down the hall afterwards. And then again, all of this is really done through support of, we have just amazing support from individuals and foundations, and they really help support our grand rounds, the network forum, the Tai Chi Qigong conference, our research programs as well. So if you feel inclined, please do consider. So with that, thank you, everyone. We look forward to seeing you at next month on Tuesday, December 2nd. So be well, everyone. And again, thank you, Dr. Patel, for just an amazing presentation. So we'll see you next time.